Please welcome Assistant Vice President, Federal Affairs at NCQA, Eric Musser, and Deputy Administrator and Director, Center for Medicare, CMS, Dr. Meena Seshamani.
Well, welcome, Dr. Seshamani. Thank you for being here today.
Thank you for having me.
We know it's an extremely busy time at CMS, so we really appreciate that you were able to join us at the Health Innovation Summit this year. First, I just want to personally thank you. Your role in crafting the ACA, and particularly those provisions around protecting folks with pre-existing conditions, was monumental in my personal and professional experience, and helped me, reach my dreams without the potential of losing coverage. So first and foremost, thank you for that.
Absolutely.
And so you've had a stellar career and been involved in some very impactful policymaking with the ACA. But how have you taken some of those experiences and now used them in your role now directing the Center for Medicare?
Thanks for the question, and it's great to be here with all of you today. As a physician and a health economist, I've had the good fortune to be able to bring those various perspectives and areas of expertise to bear as we are grappling with some of the most complex questions and issues that our country faces. And so, from working on the Affordable Care Act and really thinking about how it's so important that we keep the people that we're serving at the center of what we're doing, where we wanted to make sure that we were reaching those who did not have access to coverage, who felt they were locked in a job so that they could maintain their health care coverage, to all of the work that the ACA did on transforming care and delivery system reform, setting up the Innovation Center. It's so important to hear from those on the ground what they see as the changes that need to be made to incorporate into policy making, and then when you make policies, when you implement programs, to really partner so that they can go that last mile to really change the way that care is provided. And I think that's a perspective that I bring to my current role now as well, as we are, driving increases in value-based care, making significant strides with implementing the new drug law, the Inflation Reduction Act, and with the work that we're doing around strengthening Medicare Advantage and traditional Medicare.
That's great. And so you haven't just been a policy wonk, you've been a practitioner for many years. And so how has that impacted how you view your policy making today?
Yeah, well, it's kind of the flip side of the coin of what I was talking about, because I have, until very recently, been on the other side where you say, there are a lot of things that I see as I'm taking care of a patient that could be improved, and wanting to make sure that others hear that, but then also that you can roll out all these great policies, but if people don't understand them or know about them, then they're not going to have the impact that you want. And, as a physician, I'm sure many of you who work in healthcare, you have countless stories of the people who need support where the healthcare system has either worked for them or has not worked for them. Just with the ACA, I'll give a quick example. I had a woman who came to my clinic with an enlarging neck mass, and I, did my physical exam. I was pretty sure it was thyroid. I was pretty sure it was cancer by the speed with which, it had been growing. And I wanted to send her for imaging and to get a biopsy. And she told me that her health insurance only covered office visits and prescription drugs. And so she could not get that further workup. It was in October. I said, hang tight, because in November, it's open enrollment for the Obamacare marketplaces, and I directed her to DC HealthLink. She got an Obamacare plan, and then, sure enough, it was cancer. She was able to get her thyroid removed. And now, fast forward, and, the Biden-Harris administration has, issued regulations to, clamp down on those, skinny health plans to make sure people have good coverage. that's an example that's separate from the work I'm doing now, where I took care of people who couldn't afford the prescription drugs that, we wanted them to take, where leading care transformation for a major health system, we had that big spreadsheet with 8-point font of all the quality measures for all the different programs that we were being held accountable to, and the confusion that created and the hindrance that created to really driving changes in care. So all of these experiences, they're stories that I bring with me to the role that I have now, and I want to continue that dialogue, that two-directional partnership if we want to really drive change and have the most impact we can for the people who rely on us.
That's really great. And I know that this year in the physician fee schedule, you all were really thinking about families and caregivers. My dad, a traditional Medicare beneficiary, for me, this was the first year where I really had to be involved in his care and take a more hands-on approach to helping him manage those conditions. So I know that you put some proposals forward in those rules for caregiver support. Could you explain those proposals and how they've been received so far?
Yeah, absolutely. It's very exciting. Again, I think being able to take experiences caring for patients, experiences that we've had navigating the health system, to really try to change the system so that you're caring for people rather than just treating a disease. And in that vein, there are 3 proposals that, I'll highlight. The first is one directly that you mentioned, where we're proposing to pay for caregiver training. I think especially with older populations, with disabled populations, many times there are caregivers who are the backbone in really helping that person to live a healthy life, to navigate the system, and that person needs support and resources. And I know the prior panel was on equity. I think we also know the equity implications of that unpaid caregivers tend to be in, more underserved communities, communities of color, and so really being able to propose payments where then, a clinician's office can help train caregivers in how to best care for their loved ones. Related to that, we proposed payment for care navigation, principal illness navigation services. So for people who have, complex chronic conditions, to pay for someone who can support them as they have to navigate the healthcare system. Because to leave it to an individual who oftentimes is not feeling well, and again, there are equity implications here as well. Not everybody works in healthcare and understands all the lingo. Not everybody speaks English fluently to be able to communicate. So being able to pay for those supports, is something that was important for us. And then the third is we've proposed to pay for community health services for the first time in the Medicare program, community health integration services, so that you can integrate care for health-related social needs with the overall care that somebody is getting. And I think those are examples of where we're really trying to open the aperture of what healthcare means for people, for their families, and for their communities. And we're right now in rulemaking, evaluating the comments, and we'll move forward with finalizing.
Well, yeah, that's great. I know NCQA submitted comments and was very supportive of those. And so, I really, NCQA has a health equity accreditation program, and we have a health equity plus program that are really core to addressing some of those health equity goals that many in this room have. So we're excited by your proposals, and thank you for putting them out there. We look forward to having that rule finalized. John Blum joined us yesterday and was on stage with Peggy O'Kane, and behavioral health is a focus for NCQA. We know there's lots of struggles with access and availability. Your rules again this year had some proposals to expand access. Why was that critical, and why now?
This is another thing I'm so excited about. We are proposing some of the biggest changes in behavioral health in the Medicare program in decades. And to your question of why is it so important, I will come back to my experiences as a clinician. When I led care transformation for the health system, one of the programs that was under my purview was our diabetes care management program. And when we were looking at the diabetics who, had high hemoglobin A1Cs, or diabetics who were coming, repeat into the emergency room, more than 2/3 of them have a behavioral health comorbidity. And to just address the diabetes, again, treating a disease rather than caring for a person, to just try to address the diabetes without considering maybe this person has anxiety and depression and can't even get out of bed, let alone then try to change their diet, take their medications. And so it's been very important for us to really drive integration of behavioral health into overall care and to really support behavioral health. So what we've proposed now are to, again, following congressional action, to allow licensed marriage and family therapists, licensed mental health clinical counselors, including addiction counselors, to be able to enroll in the Medicare program and directly see patients. We also are proposing to create an entirely new benefit in the Medicare program, an intensive outpatient program, because currently you have acute inpatient, partial hospitalization, and then nothing, and then seeing your outpatient therapist or behavioral health provider. So being able to fill that gap with an intensive outpatient program is something we've proposed, that we're very excited about. And also, we have already finalized things like paying clinical psychologists or social workers for providing behavioral health as part of a primary care office visit, or we're proposing to increase payments for psychotherapy in crisis services. So really trying to find all of the avenues where we can best support behavioral health and address many of the gaps that currently exist.
You mentioned health equity earlier. I know that has been a primary goal of this administration since day one. But doing health equity and payment policy is a challenge, and I think it's something we're working through as a society. I wonder what you've seen from your professional experience to that you're now working into policy. I believe that just last week you published something with in JAMA with Dr. Michelle Schreiber, who will be on this stage later today. So could you describe that to us and what you think is possible in Medicare?
Absolutely. Well, a lot of what we have been talking about all has direct implications for health equity, right? We talked about proposing to pay for community health services, for caregiver training, for care navigation. Behavioral health has tremendous equity implications. And so I think what's so important is that understanding that addressing health equity isn't, let's just create a program to advance health equity and it's over here, and then we'll run our program, but look, we're doing this on health equity.
Right.
It really is about incorporating equity into absolutely everything that we do. And in the Medicare program, that's particularly important because we operate the largest payer in the country, right? Almost $1 trillion in claims, more than 65 million people. How are we making sure that the program is as easy to navigate as possible? How are we making sure that our oversight, our outreach efforts, our auditing is all with an eye towards making sure that those who have complex, medical and social conditions aren't the ones that fall through the cracks. I was meeting with my team and we were talking about some oversight and auditing work, and there was a really unfortunate situation with a patient where the referral loop wasn't closed with the specialist. And they're like, well, this is the work we normally do. It's not health equity work. And I said, well, what language did that patient speak? And sure enough, he was a Spanish-speaking elderly gentleman who didn't have family support. So he didn't have the resources to be able to, on his own, necessarily, connect all of these dots. So really, everything that we do has equity opportunities and equity implications. You mentioned about the JAMA article that we just published, and that really brings a lot of what we're talking about to bear, where we want to say, how do we reward excellence for underserved populations? I think in the quality space, there has been an ongoing debate about risk adjustment. Right. Do you risk adjust for some of these, demographic, socioeconomic characteristics because, the outcomes might be different? And the concern is that then you could risk adjust away the work that needs to be done. And so instead, what we are leaning into is saying, if you are caring for underserved populations, and if you meet the quality thresholds and metrics, you get extra rewards. So that way it creates a virtuous cycle rather than a vicious cycle where you can then invest more money into these kinds of programs. And importantly, we are aligning these concepts across all of our programs. We also published about the National Quality Strategy and setting up a universal foundation, a core set of quality metrics. Maybe I'm stealing your thunder, we were going to go there next. But where we can try to align across our programs, well, taking this equity in quality concept, we have implemented a health equity index in Medicare Advantage, a health equity adjustment in the Medicare Shared Savings Program, and a similar reward for underserved populations in the inpatient prospective payment system for hospitals. So taking that concept and aligning that concept across our various programs and payment systems so that everybody is rowing in the same direction to drive change.
Yes, there's been a lot of discussion about the Universal Foundation at this conference. Peggy started the conference with applauding CMS for this bold initiative. We think that it's the right first step, and we're excited that NCQA supported as well. How do you view the Universal Foundation in driving some of the agency's other goals around accountable care? I know you put out a bold goal for all Medicare beneficiaries to be in an accountable relationship by 2030. That is a big goal. And are there some steps that you envision that we can take to get there? Feels like in some ways, the value-based care movement has plateaued some. So I'm wondering how the Universal Foundation might support some of your broader accountable care goals.
Yeah, so coming back to that big spreadsheet that I told you all about, it struck me when I was leading care transformation in my last role that people were spending time arguing about whether we have to hit hemoglobin A1C greater than 8 or hemoglobin A1C, greater than 9, rather than focusing on how do we improve care for our diabetics. And, to be able to align on a core set of metrics enables us to focus our attention to where we need to focus in really driving change on the ground. And that is very important for transforming care, for moving to value-based care, because change is hard, right? It's human nature. And a lot of what we're trying to do in terms of aligning across our programs is to help people develop the capabilities, develop the muscle memory, so that they can have the confidence to be able to take on more risk, to be able to be held more accountable for quality measures. So as we look at from the fee-for-service chassis, right, what we talked about, the community health, care navigation, all of these things are part of the core of what you need for a team-based model of care, for total cost of care. So if you can encourage that in the everyday chassis of the Medicare program, then people can develop that muscle memory, they get the resources they need to then move into an accountable care, accountable care organization. And similarly, our alignment on the other side with the Innovation Center, where they can be that R&D arm for Medicare and Medicaid, where they can test concepts that then, if they work, could be scaled into the Medicare program. And a good example of this is that the Innovation Center had an ACO investment model to provide upfront funding to providers to invest in infrastructure and teams to become an ACO, and it was found to be successful and great. It was a successful model, and it just sat, right? And so we came in and said, wait, we can scale this into the Medicare program writ large. And so in the Medicare Shared Savings Program, the largest accountable care organization program in the country, right? There are 525,000 clinicians, I think 11 million beneficiaries. We now have a program, Advanced Investment Payments, where we give upfront dollars to small providers in rural and underserved areas that they can use to become an ACO. And again, the test that in the Innovation Center did showed that that's a really good investment, that over time they will save money to pay back that loan and have some savings besides, and they make incredible improvements in quality for their communities. So that's just one example of the partnership and alignment on that, testing end as well.
Yeah, that's great. And we were excited to see, you mentioned CMMI, the Making Care primary also has some of that upfront infrastructure investment to help providers move into value-based care, which is so essential. We're a couple days out from open enrollment. I know that's probably keeping you...
open enrollment is now.
You're right, my bad.
October 15th it started. Note, everyone.
Yes, sorry, that was the exchange, right? Back to my father, we've been thinking more...
So now you need to talk to your dad because it's already started.
Well, yeah, he's... We'll get there when I get home. I think we've been considering, a change into Medicare Advantage to get some additional supports. But when we look at on TV, and John brought this up yesterday, there seems like there's 1,000 plans to choose from if we were to go that route. So how are you helping consumers make those choices, regardless if it's in Medicare Advantage or traditional Medicare?
Yeah, so open enrollment, October 15th to December 7th. And it is so important for everybody every year to evaluate their options, because as you all know, people's health needs change, their financial situation can change, the options that are available change each year. And importantly, right now, there are a lot of significant changes happening with Medicare because of the Inflation Reduction Act,
right,
the new drug law as well. And it is very important to us. This circles right back to where we started about how you can have these great programs and policies, but if people don't understand them, know how to navigate them to figure out what works best for them, then you're not having as much impact as you could. So it's been very important to us to work to make things easier to navigate. So a few things. Number one, that Medicare.gov and 1-800-Medicare are the official sources of information on Medicare and the options that are available. And we've done some revamping of Medicare.gov. So when you go in, one of the first things that you come to is understanding what traditional Medicare is vis-a-vis Medicare Advantage, right? Where at its most basic level, traditional Medicare, you can see any clinician in the country who participates in Medicare. About 98% of clinicians participate. On Medicare Advantage, you can only see a clinician who is in the network of that plan. And Medicare Advantage can provide some additional benefits like dental, hearing, vision. So kind of thinking at that high level of what it is that you need. And then from there, people can input their prescription drugs, and they can do side-by-side comparisons of their options to see what works best for them. And it's very important that we emphasize that Medicare.gov and 1-800-Medicare are the official sources of information, because to what you commented on, there is a lot of marketing that happens during this period. We have heard about the misleading marketing, the confusing practices. We have heard from clinicians who say that their patient got switched to another plan, they didn't even realize it, and now their doctor, who they love, is no longer in the network and they can't see that person anymore. So a few things there. Number one, we are reviewing every TV ad to make sure it's not misleading. And in fact, our team rejected 300 ads this open enrollment cycle so far as being misleading. And we finalized a whole series of regulations around for oversight of misleading marketing practices, such as you can't use the Medicare logo or Medicare name in a misleading way, that if you're selling plans, you have to be specific that you are selling specific plans. You're not giving the full range of Medicare options, and reiterating that 1-800-Medicare and Medicare.gov are the official sources. Separating sales events from educational events. So we put a lot of regulations in place that have started this open enrollment cycle to try to address some of these misleading marketing practices as well.
Well, that's great, and thank you for that. I think that's super important. I have one more question. We will have time for a few questions from the audience, so if you want to make your way to the mic now for any questions for Dr. Seshamani. This is the Health Innovation Summit, and as somebody who likes to dive into thousands of pages of federal rules, I know that some of the most innovative policies are often buried in those thousands of pages. So I was wondering if there was one or two policies that maybe aren't getting the same attention in the media that you would like to elevate here today.
Oh, where do I begin? Well, I will, I know that there's been a lot of conversation around equity, and, we have talked about how equity really needs to be in every single part of everything that we do. One example, in the inpatient prospective payment system, we recently finalized that homelessness can be considered a complex chronic condition that can adjust DRG payments for the hospital. And I think that's very important, right? I mean, and in some ways, hopefully, this can start to address the vicious cycle that occurs where we have Z codes, but people aren't necessarily coding the Z codes for social determinants of health, because what difference does it make? But we need to know the code so that we can pair it with the costs of caring for that person, so we can see, does this person require more resources that we should be paying more? Right. So, the homelessness, we saw a direct link between the Z code being coded and the resources required to care for that person. I know that is not a surprise to anybody who works in healthcare, not a surprise to me, as case management in the hospital was something else that I led in my prior role. And so we were able to utilize that data to say, we will include that as a modification on DRG payments. And it doesn't have to stop there. This is where it's so important to partner, where if we can get that data, if we can have people coding those Z codes so that we can see where additional resources are needed so that we can make sure that we are supporting it. That also comes back to that JAMA article of how do we reward excellence? How do we provide the support and the resources where it needs to go? So that's an example of a more technical, perhaps, area. And
great.
Rules.
So I think we have time for one question. So go ahead and please introduce yourself.
Hi, I'm Joe Stankaitis. I'm a physician. I have a question on the policy side regarding patient well-being. That being, is there anything happening on the horizon for oral care coverage under standard Medicare, given the fact that poor oral hygiene, periodontal disease are accelerators for cardiac disease, diabetes, any other chronic illness? Is that going to happen soon, given the fact that it is covered under a lot of Medicare Advantage plans? Thank you.
Absolutely, and thank you for asking that question. I also have a clinical interest because I'm actually an otolaryngologist, so I deal with the mouth all the time. And yes, in fact, last year we did a few things. Number one, we codified and expanded some of the existing ways that traditional Medicare pays for dental services, where dental services are paid for if they are inextricably linked to the success of a medical service. For example, with organ transplantation being a good example, with the treatment of head and neck cancers. And we also established a process by which we can get input. This again comes back full circle to what we were talking about. a process by which we can get input from all of you where there are areas that dental services are inextricably linked to the success of medical care. And we have gotten a lot of information through that process that we are working through as part of our current payment cycle. You know, we got more information, you know, about head and neck cancer. People have been talking about sickle cell disease, right? There are lots of areas, you mentioned cardiac disease. There are lots of areas where we want to, you know, partner with all of you to see where there are those areas that dental services are inextricably linked to medical services. And you may be saying, why is she using this strange language, like inextricably linked? The reason is because, you know, we have to work consistent with the Medicare law.
Right.
And so the Medicare law says that, you know, like routine cleanings, like that's dental care, which is not covered. But if the dental service is part of that medical care, then that is something that we have been, you know, looking into and seeing where we can pay.
Well, thank you, Dr. Seshamani. We are at time. We really, once again, appreciate you being here. That brings us to a break. In the breakouts, there will be a session here that starts in 10 minutes on building trust in clinical data for value-based care. Thank you for making it through the conference so far, and enjoy the last day. Thank you so much.